Good evening, everyone, and welcome to Cure Talks. I'm Priya Menon, your host, and today we are discussing how to manage endometriosis leading to infertility. The relationship between endometriosis and infertility has been debated for many years, and joining us today to help us understand the condition better is Dr. Suneeta Senapti, Assistant Professor of Obstetrics and Gynecology from the Hospital of the University of Pennsylvania. The patient perspective will be discussed by the patient advocate panel comprising of patient advocates Casey Berna, Heather, Arnold Brown, Anna, Lucia Krupp, and Valerie Landis. Welcome to everyone to Cure Talks. We will be addressing questions from the audience towards the end of the discussion. So if you have a question for the panel or for the expert, you can send it in to priya@trilix.com, or you can also post your questions in the comment section. Before we actually dive into how to manage endometriosis that may lead to infertility, I think it's important that we kind of define what endometriosis is first. So Dr.
Sure.
Senapti, what is endometriosis and what are some of the symptoms that it presents with?
Absolutely. Well, first of all, Priya, thank you for having me on the show, and I'd like to thank all the panelists as well. It seems like you guys are all going to bring a very unique perspective to this conversation that I think will be very helpful. So to start off with, endometriosis is a condition that affects about 10% of individuals who are born as females, and some of the most common symptoms that women can have can include painful periods, pelvic pain or abdominal pain that exists both during periods and outside of periods. And another common complaint can be pain during sexual intercourse. Some women with endometriosis may also note some irregularities in their menstrual cycles, particularly some spotting just before their period is due. And at this point, endometriosis is a condition that can be suspected based on symptoms, but at this point it really does require surgery to make a definitive diagnosis. And so, endometriosis is a condition in which the cells that are typically in the lining of the uterus or the womb actually present in other places. So we can see them as lesions or spots inside the abdomen. Sometimes we can see cysts on the ovaries called endometriomas, or it can present as more of a fibrotic disease type that causes internal organs to stick together. We don't know exactly what causes endometriosis in terms of why some women develop it while others do not, but there are some clear risk factors, and we do know that it is an estrogen-dependent disease that can really present very differently from one person to the next. I think one of the most important things to know about endometriosis is to understand what the symptoms are, and as many of the panelists alluded to, a lot of women suffer in silence for a long time, and sort of the average time to diagnosis of endometriosis can be many years after the initial symptoms present. So, it's something that we certainly want people to be more aware of in terms of how it can present, so that we can really direct people to who needs treatment.
You did mention pelvic pain as a symptom for endometriosis, but I believe pelvic pain may also occur due to other medical conditions. So how do you differentiate between pelvic pain due to endometriosis or for something that is due to some other medical conditions, for example, interstitial cystitis or fibromyalgia?
It's a great question, and what we do see is that many women with endometriosis can have multiple different types of conditions that can cause pain syndrome. So, for example, some women with endometriosis may also have fibromyalgia or interstitial cystitis. I think in terms of really differentiating, where is the pain coming from and therefore, what's the best way to help treat the pain, really gets at understanding some of the other symptoms that may be present. So, for example, if patients have pelvic pain that seems to be more related to when they have a bowel movement, for example, or more problems with diarrhea and constipation. That may point more towards an irritable bowel-like syndrome. And certainly similarly, if it's a bladder condition, they may notice more discomfort when urinating. So kind of understanding what are the other symptoms that come with the pain can be very helpful. And also, many patients with endometriosis may notice that the pain is more cyclic, meaning they'll notice it more kind of leading up to or kind of during the times when they're actually on their period. So the cyclic nature of the pain in some cases can help point more towards endometriosis than some of the other conditions. But I do think it's important to kind of anytime we see this, we really try to do a comprehensive assessment of other things that could be going on so that we address the endometriosis, but certainly can make sure that we are identifying and therefore, providing the opportunity to address other syndromes that could be happening at the same time as well.
Dr. Senapti, this is just my curiosity. When I was reading up, preparing for this talk, actually, as you said, I saw many of the symptoms mentioned, what you just mentioned. So in your years of treating endometriosis, have you ever seen something which is so very uncommon and so very uncommon presentation of this condition, and it was difficult initially to diagnose this as endometriosis?
So, we every once in a while will have some pretty unusual cases of endometriosis. For example, a patient that actually ended up in the hospital because she was coughing up blood at the time, every time she got her menstrual cycle, suggesting that she actually had endometriosis involving her lungs. And kind of was developing fluid collections related to that. So that's, one example of some of the more unusual cases that we see. And I think really speaks to the fact that while there's some things that are very typical of endometriosis, it can also, in some rare cases, actually, cause problems outside of kind of the typical gynecologic types of conditions and problems that people see women's healthcare providers for. And so, I think those are situations where it can be really helpful to kind of approach things from a multidisciplinary perspective and really kind of keep it at the back of one's mind anytime you're evaluating or kind of treating a woman who is of reproductive age. Is this something that could be related to her cycles and possibly endometriosis?
Dr. Senapti, you did touch upon, causes, saying we really do not know all the causes of endometriosis. So my question is, endometriosis has been associated with several chronic diseases, like you just mentioned, and then you have cancer, autoimmune disease, asthma, allergic manifestations, and cardiovascular disease. Can you talk a little bit more about the causes of endometriosis? Also, I want to club one question that came in. I think this was one of the first questions that came in for this talk. The question is, some women with endometriosis may also have other immune disorders like eczema, asthma, and fibromyalgia. Are we saying that endometriosis is an immune disorder?
So it's an interesting question, and I think it gets at the idea that, while we've made a lot of progress in learning ways to treat some of the symptoms of endometriosis, we don't fully understand yet what exactly causes endometriosis, or kind of more specifically why some women get it and others do not. Some of the theories or kind of ideas behind what may be causing endometriosis, one of the more popular theories has to do with the idea of retrograde menstruation, or that some of the blood and endometrial tissue can kind of get flushed back into the abdomen when a woman is menstruating. And in a subset of those women, they can form these lesions or spots. There's also some theories about coelomic metaplasia, or basically cells changing a little bit, inside the abdomen. The idea that endometriosis can spread through the blood and lymphatic system, which can explain some of the more distant sites of endometriosis that we see. And, there are still others that believe that there may be kind of a genetic or multifactorial component to things. What we do know is that endometriosis does seem to be an estrogen-responsive disease, meaning if we block estrogen or some of the hormones, or I should say enzymes that make estrogen, that can sometimes help with the treatment of the symptoms. And we've also seen that there can be a component of the immune system that may be altered. So immunomodulatory effects may be slightly altered in women who have endometriosis, resulting in a state of kind of chronic inflammation, which is why I think it has been associated with many other types of chronic diseases in which inflammation or altered immunomodulation may be part of the spectrum. So in response to the question, is endometriosis an immunologic disorder? I think it's in part. I think that it's a hormonal disorder, it is an immunologic disorder, and I think it can manifest in a lot of ways that can be linked to other disease processes as well.
Thank you, Doctor. So we come to that question that we're going to the topic that we're discussing today. So how does endometriosis lead to infertility?
Yeah, so endometriosis is an interesting disease in that it can be linked to infertility, and about 30 to 40% of women with endometriosis may struggle with infertility, which is actually much higher than what we see in kind of the general population. The ways that we think that endometriosis can cause infertility include changing the eggs, or basically can be linked to changes in the egg quantity or quality. We see that endometriosis can be linked to diminished ovarian reserve, which is kind of an independent infertility diagnosis. We've also seen that endometriosis can certainly change the pelvic anatomy, and we can see that in the fallopian tubes in terms of causing scarring or distortion of the fallopian tubes. We've also seen that in some cases it can alter how a pregnancy implants inside the uterus, or specifically altered both hormonal functions from the perspective of progesterone resistance on the endometrium, as well as some other cellular mediated functions. And as I mentioned before, endometriosis is a state of there tends to be a lot of inflammatory cells, and we think that may alter kind of the peritoneal environment, or the general environment in which a pregnancy is occurring. So all of those factors can, independently contribute to why a woman may be having difficulties conceiving, and we tend to see those kind of manifest either individually or in kind of multiple aspects being affected in many women.
Mm-hmm. Dr. Senapti, I do have a couple of more questions for you, but being mindful of time here, I'm going to hand it over to Casey to start with hers. Sure. Casey is an endometriosis and infertility advocate. Casey, please ask your questions.
Hi. So I was wondering, endometriosis can be, and you talked about this a little bit before, a complex multi-system disease to treat. There's some research that showed that there's links to endometriomas and invasive bowel disease. So I guess my question is, and I know I had endometriosis on my bowels and on my bladder, what multidisciplinary treatments do you recommend to patients to help with chronic inflammation and pain, sort of even outside of fertility treatment?
Sure. So, I think in any patient with endometriosis or in whom you suspect endometriosis, I think some of the tenets of approach involve understanding what are the symptoms that are most debilitating to the patient. Why is she here to see us? And then how can we address those symptoms directly, but also thinking about sort of from a more holistic perspective, preventative measures on down the road as well. So that may include, working with a gynecologist on different types of hormonal management, either birth control pills or gonadotropin-releasing agonists or aromatase inhibitors. There's many classes of medications for that. It may involve surgery. It may also involve recognizing that above and beyond sort of the symptoms directly, that it may also be impacting a lot of other aspects of their life. So, for example, if women have chronic pelvic pain, it can change sort of how their muscles sit in the pelvis, or they can have situations where they have pelvic floor dysfunction, and they may benefit from things like pelvic floor physical therapy. Many of these patients are, in a situation where they are in and out of work, and it's significantly impacting their quality of life. And there's absolutely an increased, we see an increased prevalence of depressive symptoms and anxiety symptoms, and identifying that and, making sure that patients have access to mental health support and other sort of lifestyle treatments that can help above and beyond sort of the medication and the surgery, I think are also very important. You mentioned, endometriosis in the bowel and on the bladder. Oftentimes in severe cases, we do also collaborate with gastroenterologists and colorectal surgeons and urologists, or really kind of specialists in the organ systems that are involved above and beyond simply the uterus and the ovaries. So I think that in every situation, it's really important to get an understanding of what all is involved, and then being in a setting where you can provide that or really have access to that multidisciplinary care is really important.
I agree. I think multidisciplinary care has helped me a lot. Seeing you talked about a surgical specialist who operates on a team who's able to sort of, excise the disease, and then, having the multidisciplinary support of pelvic floor therapy, mental health support, acupuncture, nutrition. That definitely all has helped me kind of thrive and, manage my inflammation and my pain.
Good to hear.
My next question was, if a young patient has been diagnosed with endometriosis or has a family history of endometriosis, what steps do you recommend that they can be proactive about their fertility?
Yeah, so Casey, this is a great question, and it's one that I think is certainly going to be evolving, particularly as fertility diagnostics and treatments continue to evolve. I think the first step is having the conversation, and I think a lot of times the focus is on the symptoms that are in front of you. So dealing with the pain, dealing with the irregularity in the cycles, and pain with sex, and all of those elements. But also I think it's important to open the discussion early in terms of, if someone has a diagnosis of endometriosis, what does this mean in the future for them? As I mentioned, not everyone with endometriosis is going to have difficulties getting pregnant. And typically what I advise my patients are, if they are, let's say they've had surgery and they're now, on birth control pills to suppress their periods, I usually tell them, when they're ready to start a family, stop whatever contraceptive method is being used, whether it's an IUD or birth control method. Try for somewhere in the range of 6 months, but certainly track the cycles in between there as well, because, I would say that most providers will say try for a year if someone is under the age of 35, but I think in patients with endometriosis, we need to have a slightly heightened awareness that some of these patients, are going to have more trouble. And so I think, having it on the radar to have the discussion and see a fertility specialist on the earlier side of that process is important. I think some of the other modalities in terms of fertility testing metrics, things like ultrasounds to look at antral follicle counts and anti-Mullerian hormone levels, we're still trying to understand how best to utilize that information in terms of counseling people who needs to be, I guess, worried, so to speak, earlier versus not. I do also see patients that come to see me interested in freezing eggs, for example, knowing that they have endometriosis and just, not being ready to try to build a family quite yet, but to potentially have that option available to them in the future. So I think all of those are important to discuss. And again, every patient's going to be a little bit different in terms of what they're experiencing and what their prognosis may be moving forward. But I think the first step is, like I said, just to start the conversation so that it's on the patient's radar, their provider's radar, so that it is something that, even once a year can be readdressed and potentially find the right time to intervene if appropriate.
Excellent. I know, Bev, you talked a little bit about the classic endometriosis symptoms, and they can be, painful periods, pelvic pain, ovulation pain, painful intercourse, and also, painful bowel movements, leg pain, back pain. It could there could be a lot of symptoms, chronic fatigue, but also some patients are asymptomatic, and the only sort of sign of them having endometriosis may be that they are having trouble conceiving. Have you found this to be true in your practice, as some of your unexplained infertility patients have you found them to actually, be endometriosis patients upon diagnostic labs?
Yeah, it's a great question, and I think that the answer is yes. So we absolutely see people who initially come, and their primary reason for seeing us is because they're having difficulties getting pregnant. And then, as we go down the route of, additional diagnostic testing, it may be that, on an ultrasound, it looks like they have an endometrioma, or, if in kind of conversations, we then realize that, I guess I do have, painful periods, but I guess I never really thought that they were any worse than anybody else's. I can't tell you how many patients say exactly that to me. They say, well, I just thought that this was, part of being a woman, and then when we go in and do the laparoscopy, we'll see endometriosis. I think one of the really interesting and tricky parts about endometriosis is that we see time and time again that the symptoms don't necessarily correlate with the disease that is seen, whether that is at the time of surgery or, difficulties with infertility. We just really see very little kind of correlation between how much we see at the time of laparoscopy and what a woman experiences. So I think my approach to it is to really have it on my radar as a potential possibility, and if after further investigation, I strongly suspect it, then that is a situation in which, doing a laparoscopy or the next steps may be helpful. Now, there are also patients with endometriosis who, if they are otherwise, asymptomatic, we may just simply suspect it based on ultrasound findings, that we may go straight into fertility treatments as well. And both of those are acceptable. But again, I think it really comes back to having the discussion with your doctor in terms of, what are the symptoms, what are we seeing, and what is the best way to treat this, both in the short term and in the long term, based on symptoms and current goals.
Thank you very much, Casey. We'll round back to you for your, if you have more questions. Next, we have with us Heather Arnold Brown, who was diagnosed with endometriosis in 2016. Heather, please ask your question. Heather, can you hear us?
Oh, I'm sorry. Can you guys hear me?
Yes.
Hello, can you hear me? Okay. Since endometriosis and retrograde menstruation coincides together, from your experience, would you say either or both affects the quality and mobility of eggs?
So I would say that potentially both can impact the quality and mobility of eggs as follows. So, retrograde menstruation is one of the theories that has been described to explain why endometriosis may happen. What's interesting is that most women actually have retrograde menstruation, but only some of those women have endometriosis. So it doesn't fully explain, why endometriosis happens. But in theory, in some women, that could be sort of the first step in getting some of that endometrial tissue into places where it's not supposed to be. In terms of the quality and the mobility of the eggs, there are some studies that have suggested that that egg quality may be compromised by endometriosis. There aren't good ways to test that in patients right now. A lot of people will use surrogates like some of the other ovarian reserve tests to try to understand this better. As far as mobility of the eggs, that can really refer to a couple things. One, someone's ability to release an egg, and most of the time, the ovulation part isn't dramatically impacted by endometriosis. But the other piece of mobility can come into play when people are going through fertility treatments like in vitro fertilization, for example, in which, a surgery is needed to extract eggs, and sometimes if endometriosis has changed the anatomy, that can make it a little bit more difficult. So in summary, I would say that, we can see both endometriosis and retrograde menstruation together, and it's probably the endometriosis inherently that affects egg quality and mobility more so than retrograde menstruation alone.
Okay, that makes sense. My second question, in many cases, endometriosis patients experience dyspareunia, which is painful intercourse. What are some tips you suggest where sex or intimacy won't feel as uncomfortable or like a task or a chore?
Sure. So, painful intercourse is something that a lot of patients will describe or kind of elicit on questioning. A couple things that can be helpful. One, certainly making sure that lubrication is involved, and there are some types that are better for women who are actively trying to conceive versus not. Some women that have pain during intercourse may also have pelvic floor dysfunction. And so this is a situation in which things like pelvic floor physical therapy can help relax some of the pelvic floor muscles and make it such that intercourse is less uncomfortable. Depending upon what other treatments are involved, there are some women who, particularly if the endometriosis is happening sort of behind the uterus in what we call the rectovaginal space, they may benefit from certain surgical techniques to destroy the endometriosis in that area. But I think it's certainly kind of approaching things from all of those perspectives is important. It may be that one works better than the other, or it may be that for a given woman, all three of those may be helpful.
Okay. And my last question, the curriculum for endometriosis averages about 20 minutes or so. So what are some steps that we can take to get more doctors educated and aware of the severity of endo, making it easier for an earlier diagnosis as well as proper treatment?
Yeah, so I think that I think one of the most important things that we can do is to raise awareness about endometriosis, certainly amongst patients so that they're asking about it, but also on the medical community side. We do a lot of education with our residents and fellows about endometriosis, both kind of sit-down conversations like this, but also encouraging, people to think about it anytime someone comes into the office or into the emergency department with abdominal or pelvic pain. I really think that it should be sort of on the list of things that people are thinking about from the get-go, along with other kind of other disease processes too. So, I think that making sure that it's a staple part of medical school curriculum is helpful. But also, I think for all women's healthcare providers, many patients will see nurse practitioners and physician assistants, and they do a great job taking care of patients. And I think the more that the world and the more that our general community is aware that this is a real problem, I think that's really going to help patients get access to the care that they need, and sooner. I think the sooner we can get people in and really taken care of appropriately, the better it will be for everyone.
Thank you, Heather. Next, we have Valerie Landis with us. She focuses on guiding women of reproductive age through complex and challenging parts of fertility decisions. Valerie, please ask your question.
Hi, Doctor. Thanks so much. So what are some of the new proven tests and or scientific medical advancements in the marketplace that we can help not only diagnose endometriosis better, but manage some of the symptoms? Are there any new research or tests out there that you would recommend? Like, have you heard of Recepria DX? Would that be a good option for patients?
Yeah, so I think this is definitely an area that's still evolving, for certain, and I think there's lots of groups that are working on both diagnosing endometriosis early and really targeting new therapies for the treatment of endometriosis. There are some tests that have been developed that specifically look at the endometrial receptivity, and the idea, and that's the one that you had mentioned, and it's the idea behind it is that in women with endometriosis there are certain markers that are present in the lining of the uterus that may be expressed differently. The one that you mentioned in particular looks at something called BCL6. So, I think that particular test was developed to really look at patients with who are struggling with fertility issues, and I think that as with any new test, we need to make sure that we are assessing how does it perform in patients that we know have endometriosis versus those that don't, and I really look forward to these next couple of years because I think that there are a lot of interesting new options that are going to come down the pipeline that may help us to both diagnose endometriosis sooner and particularly for patients with fertility, help them to navigate the IVF process a little bit better. So, I think at this point those tests are still pretty new, so, I don't know that they've been sort of universally utilized yet, but certainly they have a lot of promise.
Great. And does birth control mask endometriosis in any way or help the symptoms? And when do you recommend fertility treatments or egg freezing for patients that are suffering from endometriosis?
So those are great questions. I'll start with the birth control one. So in answer to your question, does birth control mask endometriosis? So birth control and all the various methods, whether it be pills or an intrauterine device or the implant, they are very common methods used to treat the symptoms of endometriosis. And so utilizing those methods should be encouraged. I wouldn't tell someone to not utilize those methods for fear of being, underdiagnosed or misdiagnosed. They're very effective both for contraception, but also for managing some of the symptoms that can come with endometriosis, like painful periods or even pain outside of periods. I think that what's important is that, if someone has been on birth control for a long time and then are stopping the birth control pill to either to take a break or even, for the purposes of trying to start a family, I think it's really important to kind of take stock at that point of what symptoms may be present. So there are many women who feel great when they're on the birth control pill, and then the moment that they stop it to start to have a family, they're in horrible pain. And so, that's a situation in which I would really see, a gynecologist or potentially a fertility specialist sooner rather than later, because those are patients in whom they may, need additional management in that process of trying to get pregnant that can either, expedite the process or to help manage some of the symptoms as they go through. And I believe your second question was about egg freezing and kind of, when should one potentially consider fertility treatments like egg freezing. And this is an area that is there aren't clear guidelines at this point. What I usually tell women is that, if you have endometriosis and you're in your late 20s, early 30s, and are starting to think about having a family but are not necessarily in a position to, or are worried because you've had prior treatments that you've been told you have bad endometriosis, I think that's the time frame that is most appropriate to begin the discussion. Egg freezing may not be right for everyone, but I think it's really important that every woman is given the opportunity to talk about it, particularly if they have a gynecologic condition that could impact their fertility. And so, that's generally the time frame in which I advise patients to start those conversations. And if they are going to potentially go through egg freezing, we usually say, the earlier age, the better. But that is a more involved conversation. There may be other kind of medical factors that are involved, and also certainly every woman is different in terms of what her reproductive narrative looks like. So that's also an important part of that conversation.
And endometriosis has been linked to infertility reasons between 30 and 50%. Is that correct?
Yep, that's correct.
So does egg freezing or fertility treatments then help with endometriosis?
So that's a great question.
Symptom-wise?
Yeah, so from what we can tell, going through the process of fertility treatments to either bank eggs or embryos or to conceive does not appear to really significantly alter the course of endometriosis. Some women will report that when they are pregnant, a lot of the symptoms that they experience during when they were not pregnant are not as profound or may go away entirely. So that suggests to us that the process of getting pregnant or being pregnant does not seem to hurt the endometriosis or make it worse. If anything, you may see some symptomatic relief during that time. Egg freezing, the research so far has not suggested that it causes a progression in endometriosis or worsening symptoms. There are some hormone treatments that are involved in many fertility treatments, but they are usually a short term, usually for a few weeks at a time. So from what we can tell, they do not substantially alter endometriosis or the risk of symptoms.
Thank you, Valerie. Thank you, Doctor. Our next panelist is Anna Lucia Krupp. Anna is founder and president of the Midwest Endometriosis Association. Anna, please ask your question.
Hi, Dr. Senapti. How are you?
Well, thank you. How are you?
I'm doing good. So I know you've talked a little bit about delays in diagnosis. So here in the United States, I think that the average is between 5 and 10 years. I know it took me personally about 10 years. So in your opinion, what factors are impacting the delay in diagnosis? I know you discussed it a little bit, but if you can just speak a little bit more about what patients, doctors, and advocates can do to make sure that we receive early diagnosis and treatment.
Sure. I think that I think one step is, certainly as a healthcare provider, it's asking the question. So asking the question about symptoms, or asking the question about, and not simply asking the yes or no elements of the question, but to dive a little bit deeper. So, one of the things that I alluded to was just the concept of painful periods, and that, it's very common for women to experience some discomfort during periods. And I think many women with endometriosis kind of deal with that, thinking that it is within the spectrum of normal. But then when I ask more questions about, well, how bad is the pain, and what are you taking to manage the pain, and when you take medicines like ibuprofen, does it help the pain? If someone tells me that they're taking medicine, pretty much around the clock when they have their period, and it's not really changing their pain at all, then that, is a little bit of a flag to me that maybe there's something else going on that warrants additional evaluation. And so I think that one of the best things that we can do, and this is just kind of, from a public awareness perspective, and also as a healthcare provider, one of the best things that I can do is ask the question. But also, sure. I think, from a patient advocacy perspective, a lot of this is also about educating young women about it's almost a part of health education in some ways. These are the normal changes that all women experience, and that these are some things that, these are some symptoms that can happen, and talk to your doctor if you feel like you're experiencing something that you're not sure about. I think just allowing that is important. I think a lot of girls may not feel very comfortable talking about their periods, and so I think just having that awareness that it is okay to talk about something like this, whether it's with someone that you trust or with a healthcare provider, that is often the first step that allows us to then say, okay, it looks like we need to do more investigation.
Yeah, absolutely, and I think that kind of leads into kind of this idea of normal periods and the stigma around menstrual disorders and pelvic pain, and how that kind of impacts the diagnostic process for women with endometriosis. I don't know if you're familiar. There's a whole body of literature even just on the experience of women with endometriosis and being told that their pain is normal by family members, especially even just like because it does run in families. There's mothers with endometriosis that experience painful periods that never were diagnosed, and then they tell their daughters that their pain is normal without knowing, and then they go to the clinicians, and the same thing kind of is cyclic and told, and so those patients never get diagnosed until 10, 20 years later. I guess my one question I did have for you, so you spoke about using ultrasound and how surgery really is required to confirm a diagnosis. In practice, I think a lot of the time ultrasounds and even MRIs are used to rule out endometriosis without surgery, and so can you speak to that and how that can be harmful to patients? Because I know there's a lot of patients out there that have been told that, for example, we didn't see anything on your ultrasound, and since endometriosis can be on pelvic organs that are not visible by an ultrasound of the ovaries, or there's a lot of misinformation and confusion kind of in the patient community there, and if you can speak about that, that would be helpful.
Sure, absolutely. So, I think that imaging modalities like ultrasound and MRI can be helpful in some settings. So, for example, if someone has a cyst that is on their ovary, it can be helpful in differentiating, does this look like the kind of cyst that's related to endometriosis or not? But from purely a perspective of does somebody have endometriosis or not, well, there are some subtle findings that can be picked up, on ultrasound and MRI. Really, at this stage, there's a reason why, as of right now, the gold standard is still surgery, and that's because it's exactly what you said, in that subtle things like the lesions themselves, unless they're very, a form of deep infiltrating endometriosis, they may not be visible on imaging. And so I think oftentimes when women present with pain, the first, it's very common to have imaging initially to rule out, serious things that might need emergent intervention, like a ruptured cyst or ovarian torsion. But I think the follow-up to that is, if someone is still having pain and we're really not seeing any signs on imaging of an explanation, I believe that there is a role there for a diagnostic laparoscopy, which is a minimally invasive procedure that can be done in the outpatient setting to take a look. And, not everybody with pain is going to have endometriosis, but I think, before telling someone that they definitely don't have endometriosis, if someone has cyclic pelvic pain, I think that there's definitely a role for that diagnostic laparoscopy there.
Definitely, agreed. I know we're running out of time, but I'll just ask you one more question. So I know one experience I had as a patient is that I was also diagnosed with something called endosalpingiosis, which is kind of a variant of endometriosis. Can you speak to endosalpingiosis and endocerviciosis and how those diagnoses can confuse patients? I know in my case I actually have both, so that's unique, but some patients only have endosalpingiosis and are told that they don't have endometriosis, and that others are given the same treatments and told that they should treat it the same. So if you could speak about that, that'd be great.
Sure. So, endometriosis can have a spectrum in terms of how it presents in the pelvis and outside. And so, there are some conditions like endosalpingiosis or even adenomyosis. That's another condition that is linked to endometriosis. And I think that it's important to recognize sort of similarities and differences in terms of what the diagnosis means versus what the treatment means. And so many of the same treatment modalities are used for all of those disorders, because if the predominant symptom is pain, then the idea is that treating either the hormonal elements or, again, things like the enzymatic elements with aromatase inhibitors may be helpful. However, how that may manifest from a fertility perspective may be very different as well. So I think it's important to understand that there is a spectrum of organs that can be affected by endometriosis, and that each situation is going to be different based on what the symptoms are, what is seen either on imaging or at the time of surgery, and what the treatment goals are. So, the treatment goals may be very different for a young woman who hasn't completed her family compared to, a woman who has. And so this is a scenario in which I would say, talk to your doctor to understand how does this impact not just what I'm experiencing now, but what could happen in the future, so that, the treatment, whatever treatment is decided upon, can potentially address both things that are happening now as well as the future.
Great, thank you.
Mm-hmm.
Thank you, Anna. That was an awesome set of questions from everybody on the panel. We now throw open the discussion, so we can take some audience questions. Dr. Senapti, the first question that has come in is, the person writes about her endometriosis, right? And so so she says, I live every day feeling like a robot, forcing myself through the motions because endometriosis, adenomyosis, and fibroids have destroyed anything inside of me that was human. And then she explains about her treatments. I'm just going to cut this short. But her question is, what is the medical research community doing for women like me, and can I expect something more than just being told to take 1200 mg of ibuprofen down 3 times a day and deal with it? So in other words, maybe you could talk a little bit about latest research that's happening in the field.
Sure. Yeah, this sounds like a tough situation. And one thing that I can tell you is there's definitely a lot of interest in the medical community in making things better for patients with endometriosis, and recognizing that while we've come a long way, we still have a long way to go. So some of the treatments that have been explored are other types of medications that either act at the level of the brain, so things like gonadotropin-releasing antagonists, or that act kind of directly at the level of the individual kind of endometriotic lesions or implants, so things like progesterone receptor modulators are being studied, and there was actually, there's some interesting things that are coming out of the basic science research as well, and some mouse models that have looked at different components that are produced more commonly in patients with endometriosis, that like galectin-3, that can be linked to inflammation and the formation of new blood vessels and fibrosis, and all of the things that cause some of these the symptoms that patients experience. It takes some time to get things from sort of the bench to the bedside, but people are definitely very interested in this and continuing to work on this. And there's clinical trials all over the U.S. for some of these newer agents. So what I will say is, I hear your frustrations, and we are working on it to the best of our ability.
Thank you, Doctor. We'll take another question which says, what are some of the precautions that women with endometriosis need to take while trying to conceive?
Okay. So that's a great question. I think that one of the things to be aware of is that, for one, there's some women who, do okay when they're off of medical management as they're trying to conceive. Others will notice that their symptoms get progressively worse. So I think, working with your healthcare provider and sort of setting timelines and goals and points of reassessment are very important. So, as I had mentioned previously, I usually tell people try about 6 months, and if you're not pregnant in that time frame, that's a good time frame to at least start the conversation with a fertility specialist. I think it's also important to know that many women with endometriosis, their fallopian tubes can be affected, which may put them at an increased risk of ectopic pregnancy, or a pregnancy that could implant outside the uterus. So in women that have endometriosis, I always advise them that if you do get pregnant, it's important that you see a healthcare provider as soon as you know, so that they can, so that he or she can reassure you that the pregnancy has implanted in the right place, and that things are looking appropriate moving forward. So I think those are the two most important pieces of advice that I can give.
Thank you, Doctor. We have another question which says, if you have decided to do egg freezing at 34, 35 and are a few years off trying to conceive, but symptoms are highly suspicious of endometriosis, is it better to postpone a laparoscopy until ready to conceive, or best to investigate now to confirm a diagnosis and excise any endometriosis if found? She wants to know, what are the risks of waiting?
Sure. So, I think the decision to consider surgery is one that it warrants a conversation between the patient and the surgeon. And some of the factors that go into deciding when to do surgery have to do with the patient's medical condition overall, so other medical problems, prior surgical history, other things that might be going on in someone's medical life. But I think also most importantly, the symptoms. So, I usually guide patients on whether or not to consider surgery based on the severity of symptoms. And if this is a situation where, someone says, I feel like my periods are getting worse, or I feel like I'm having more pain over time, I think it's better to look sooner, both for diagnostic purposes as well as for therapeutic purposes. Even if one does not anticipate getting pregnant in the short term, I think from the perspective of kind of knowing, what we're dealing with, what's the cause of pain, because, endometriosis is one cause, there may be others, but also potentially addressing it moving forward. So, for example, if a patient comes to me and says that I'm not quite ready to have a family yet, but I've noticed more discomfort, we do a laparoscopy, diagnose and treat endometriosis, that may be a scenario in which I advise to consider hormonal management, like a birth control pill or an IUD, until she is ready to have a family, as opposed to not being on any medication, and then there's a greater chance that her symptoms may recur in that setting. So I think it's a dynamic discussion, but it's often driven most by the symptoms that the patient is experiencing.
Okay, we have a couple of 2 minutes, so maybe we can just take two more questions. The next one is, how is stage of endometriosis related to infertility? So, which means, I think she wants to know, do women with with very severe endo always suffer from infertility, and vice versa, or do women with the mild endo have lower rates of infertility?
So it's a great question, and endometriosis is one of those tricky diseases that both from a pain perspective as well as an infertility perspective, the stage of disease, which is something that is classified at the time of surgery, does not necessarily correlate with fertility or with symptoms in general. Now, at the time of surgery, if, for example, there is a concern that both fallopian tubes have been impacted, then that's a scenario in which that particular presentation may be much more likely to lead to infertility. And so, I think that it's important for women to be aware that, even stage 1 infertility can cause, or stage 1 endometriosis can cause infertility, but having had a history of stage 4 infertility or stage 4 endometriosis does not automatically mean that you cannot get pregnant. And so I think the flip side of this conversation is, don't assume if you have endometriosis it's impossible for you to get pregnant. If it's not a good time in your life to be building a family, make sure that you're using contraception, etc. But the opposite side of that is, if you are someone who has endometriosis and it has taken 6 months to a year to get pregnant, irrespective of what stage of disease you were told that you may have, that is a scenario in which you should see a fertility specialist.
Thank you, doctor. I think we have to wrap up now. So endometriosis is a debilitating condition in which tissues similar to uterine tissue are found outside of the uterus, most often in the pelvic cavity and on surrounding organs, causing chronic pelvic pain, infertility, and many other symptoms. Thank you, Dr. Senapti, for sharing all the great information. I think you're truly wonderful. And I'm sure you've shared so much information that would help the audience manage the condition better. Valerie, Casey, Anna, and Heather, thank you so much for participating and bringing forth the patient perspective to this discussion. I know that actually the questions continue to come in, but we have to wrap up now. Probably we will have to arrange a part 2 for this, Dr. Senapti, because I'm still seeing questions are coming in. So we thank you once again, and we also thank University of Pennsylvania and the audience. The talk will be available on curetalks.com and curetalks at Penn. So please visit our website for details on upcoming talks. Thank you, everyone, and have a great evening. Thank you.
Thank you so much.